neurology, pharmacology. So for this video, I kind of got a lot of requests from you guys asking to just kind of keep it minimized and short, just because everyone watches sketchy videos, which is what I want you to be doing. These videos are not this will not help you towards understanding pharmacology. Sketchy is a much better mechanism and tool for you to memorize what you need to learn for pharmacology in all topics. Okay. So I got a lot of kind of feedback on my pharmacology videos, and that I could just honestly minimize the amount of speaking that I do during the pharmacology videos, which is very helpful for me because honestly, it saves me time and it saves you guys time. So the way that this is going to work, I'm going to focus on some questions that were asked specifically about each of each of the medications. If I skip over medication, it doesn't mean that it's low yield or out of yield. It just means that there probably wasn't too many questions on it. All right. So what I would recommend you do once again is to watch the sketchy videos and do Anki on those, because that's going to be your most helpful resource when it comes to pharmacology. All right. So starting off, we're going to start with anticonvulsants. For anticonvulsants, you have it separated from narrow spec focal seizures, and then absence seizures only, and then you have broad spec, which is for focal and generalized seizures. Okay, so let's talk about focal seizures only, narrow spec. You have your phenytoin, your carbamazepine, and your gabapentins. All right, so first, phenytoin and carbamazepine, they both have the same mechanism of action. They block sodium channels. Okay, now what they want you to know is that phenytoin can cause DRESS syndrome. DRESS syndrome is like fever, facial edema, rash, and eosinophilia. If you see that, then they're trying to hint at DRESS syndrome caused by phenytoin, okay? It can also lead to gingival hyperplasia or hypertrophy. That's another key feature about phenytoin that they want you to know. Overall, those are the two things that I would take away. Carbamazepine, same mechanism of action, blocks sodium channel. Now, carbamazepine is the number one drug used for trigeminal neuralgia. Okay, remember, trigeminal neuralgia is like the stabbing, shock-like pain that occurs on your face from chewing or from, moving your mouth, talking, or just from like a gust of wind slightly touching your face. That lasts only a couple seconds. So that's trigeminal neuralgia, and the number one drug used for its treatment is carbamazepine. Carbamazepine can also be used for bipolar treatment, which we'll discuss later on in the psych videos. Okay, those are the two key aspects to take away for carbamazepine. Next is going to be are gabapentins. Gabapentin is going to block calcium channel, calcium channel blockers, and they can cause like ataxia and sedation, okay? Next is our narrow spec that is treated for absence seizures only, and that's going to be ethosuximide. Ethosuximide is going to be very, very helpful, and what it does, they want you to know the specific mechanism of action, that it blocks calcium channels, T-type calcium channels in the thalamus. You have to know that. It blocks T-type calcium channels in the thalamus. Okay, and it's the first line for absence seizures. Okay, very important. And then for our broad spec, focal and generalized seizures, the number one thing you want to give people is valproic acid. Valproate is very, very common. Okay, now valproic acid is going to be used. It blocks sodium channels, calcium channels, and GABA transaminase. Okay, it does all three of those things. And valproic acid, along with lamotrigine, which is another broad spec, they're going to be used in treatment for bipolar disease. They can be helpful in bipolar disease. Okay, so it's not only for focal and generalized seizures. It can be used for bipolar disease. It can also be used in conjunction. Well, not together. Just valproic acid or lamotrigine can be used to treat bipolar disease. Okay, so keep that in the back of your mind as an option. Now, for valproic acid, what you need to know is that it can cause hepatotoxicity and potential pancreatitis. All right, that's something that they want you to know. And remember that it's a CYP450 inhibitor. Okay, that's very, very key. They want you to know which is CYP450 induction, which is CYP450 inhibitor. CYP450 induction is phenytoin and carbamazepine, and inhibitor is valproic acid. Okay, now for lamotrigine, once again, lamotrigine can help to be treated bipolar disease. Its mechanism of action is going to block the sodium channels, but a very, very serious but rare adverse effect is going to be a life-threatening rash with widespread epidural necrosis. And can you guess what that is? Exactly, it's SJS. Okay, so lamotrigine is, although all of them have an increased risk of SJS, lamotrigine is the highest risk of SJS. And they can say it as life-threatening rash with widespread epidural necrosis. All right, so moving forward, we're done with the anticonvulsants. Let's talk about some barbiturates. All right, so barbiturates and benzodiazepines. Barbiturates, they're going to have like phenobarbital and pentobarbital and barbitol. Okay, now this is for our first line treatment for epilepsy in neonates. Okay, but we rarely ever use barbiturates in patients, okay? It facilitates GABA action by increasing duration of chloride channel opening. That's very key. It's duration, increases duration. Barbiturates increase duration, all right? Now, once again, it's going to be first line for epilepsy and neonates. And what they want you to know about adverse effects is respiratory and cardiovascular depression. That is the scariest part. You have respiratory, cardiovascular depression, CNS depression, very key. It induces cytochrome P450. And by the way, you can find all the inducers and inhibitors in cytochrome P450 within the book, in your first aid book. Just go look up cytochrome P450, and there's like a certain page that tells you all of the medications. Now, next is benzos. Benzos is relatively high yield, okay? So benzos are going to be broken up into short-acting and long-acting, okay? So you have diazepam, so usually they're going to end in zapam or zolam, okay? So zapam or zolam. And you can look at Sketchy once again to help you memorize which ones are short-acting, which ones are long-acting, okay? But overall, these facilitate GABA action by increasing frequency, not duration. Barbiturates do duration. Benzos do increase in frequency of chloride channel opening, okay? So very, very important, okay? So most of them have long half-lives, but the short-acting ones are going to be alprazolam, triazolam, oxazepam, and midazolam. So they're usually the olams, except for oxazepam, okay? The only one that has a PAM that ends in zapam is oxazepam that's short-acting. All the other short-acting ones end in zolam, okay? And the reason we care about that is because the short-acting ones have a very higher increase at like addictive effect. So you're at an increased risk of addiction for the short-acting ones. Okay, so now kind of like the adverse effects and overall what you need to know. So let's start with what they treat. Benzos are very helpful in treating alcohol withdrawal. That is very high yield. You have to know if a patient comes in with alcohol withdrawal, they're going to give them benzos. Okay, you can use lorazepam to minimize the side effects of alcohol withdrawal. Very, very important, okay? Now, benzos are also used for anxiety disorders, which is really helpful. Like benzos can treat rapid relief for like acute anxiety. People that are like have an acute anxiety attack, they can give them benzos. So remember, alcohol withdrawal and anxiety disorders, okay? Now, you can also use them for treatment of status epilepticus. What did I say about status epilepticus? If you're continuously seizing, the first thing you have to provide patients is a benzo because it's quick acting. Then you provide phenytoin, which is the first line agent, but it takes longer to kind of activate. Okay, so remember, benzos is your best friend for doing status epilepticus. It's going to be first, okay? Now, lastly, what they want you to know is that you should avoid benzos when taking histamine 1 blockers because they can both cross the CNS and you could have an altered mental status, especially in the elderly. Okay, so you have to avoid benzos when patients are taking H1 blockers. Keep that in mind because they can both cross the CNS. Moving on to insomnia therapy. So insomnia therapy, you have the non-benzo hypnotics like disease. So zolpidem, zalpolone, and S-zolscolone, all right? So all those are kind of just there. They're going to be acting via the GABA receptor again. But Ramelteon is probably the highest yield one that I'm going to be focusing in on. It's a melatonin receptor agonist. Okay, so it's just like melatonin. It's going to bind to the MT1 and MT2 receptors in the suprachiasmatic nucleus. Because remember, the suprachiasmatic nucleus helps with our circadian rhythm. Okay, there's relatively low side effects and it's safe in the elderly. So that is why we really like Ramelteon. All right. Now, next is triptans. All right, specifically sumatriptan. It's going to act via 5-HT agonists. Okay, it's 5-HT agonists. So very, very important. And it's just stimulation of trigeminovascular serotonin receptors. So 5-HT agonist, all that it does is going to be a stimulant of the trigeminovascular serotonin receptor. That's a question that I received, I'm pretty sure. All right. And it's going to be very helpful in acute migraines. Okay. So very, very helpful with migraines. Next, we need to talk about Parkinson's disease therapy. So the Parkinson's disease therapy, it's going to be focusing on decreasing the inability to move. So essentially, you're going to try to increase movement, right? And so what do we know about Parkinson's is that it's an overall decrease in the amount of dopamine, right? So we want to increase the dopamine that's occurring within the brain. So first, you can give them dopamine agonists. Okay, dopamine agonists, there's two types. You have non-ergot and ergot. The non-ergot are preferred. They're going to be pramipexole and ropinirole. Okay, the ergots are going to be bromocriptine. Okay, you know these from Sketchy, but what you do need to know specifically is that they'll ask, why do we not want to give like this often? Is because it leads to increase in impulse control disorder. So they're going to be, it leads to an increased risk in like them becoming addicted to gambling and doing just like random impulsive things that didn't really occur prior. Okay. Next is we want to increase dopamine availability by amantadine, which increases dopamine release at the synapse and it decreases dopamine reuptake at the synapse, okay? Next is going to be increasing in L-DOPA availability. So this is going to prevent peripheral L-DOPA degradation, right? So if we have, more L-DOPA within the periphery, it leads to more L-DOPA entering the CNS, which could then lead to increased L-DOPA conversion in the CNS to dopamine, right? Because dopamine cannot cross into the CNS by itself. It has to be L-DOPA, and then L-DOPA crosses into the CNS, which then is converted within the CNS to dopamine, right? So if we want to increase L-DOPA availability, we have to decrease its peripheral degradation. So the first thing, levodopa and carbidopa, right? Carbidopa is going to block peripheral conversion of L-DOPA to dopamine. Okay, so easy. We block the conversion of L-DOPA to dopamine in the periphery. So we keep more L-DOPA to cross into the central system. And that does it by inhibiting DOPA decarboxylase. All right, very easy. And it causes GI side effects like nausea and vomiting. Then you can have entacapone and tolcapone, which is going to be preventing peripheral L-DOPA degradation to 3-O-methyl-DOPA. Okay, and it does that by inhibiting COMT. Okay, very, very, very straightforward, and they usually give it with L-DOPA, levodopa. Next, you want to prevent dopamine breakdown, right? Because you want more dopamine. So you could give them selegiline, which blocks conversion of dopamine into dopa-C, all right, by inhibiting MAO-B, all right? And then tolcapone crosses the blood-brain barrier, which blocks conversion of dopamine into 3-MT in the brain by inhibiting central COMT, okay? Remember, this is just straightforward. This is very high-yield Parkinson's medications, but you're going to learn all of this when you're actually watching the sketchy videos. This is just really, really quick stuff that you need to know. All right, moving on is going to be neurodegenerative diseases. So for Alzheimer's disease, once again, they don't really need you to know too much about it, but the donepezil or rivastigmine or galantamine, those are kind of the agents that they like to ask about because they're acetylcholine esterase inhibitors. So we know the mechanism of action relatively well. This is the first line treatment, and acetylcholine esterase inhibitors are going to cause potential side effects of syncope and AV block with bradycardia. Okay, so that's what you need to know. So it's contraindicated in patients with cardiac conduction abnormalities because it can lead to AV block with bradycardia or syncope. All right. Moving on to local anesthetics. So local anesthetics that can be used, specifically the one that they really like to talk about is lidocaine, right? But overall, local anesthetics, what do? They block neurotransmission by binding to voltage-gated sodium channels. So when they bind to voltage-gated sodium channels, you can no longer have action potentials, right? So that's the first thing you need to know about local anesthetics. The next question I think that I would receive is that it can be given with a vasoconstrictor. So this is something I didn't know prior, but you can give local anesthetics with epinephrine, which is a local vasoconstrictor. The reason behind that is so that you can enhance the block duration of action, okay? So if you cause vasoconstriction near the site of local anesthetic placement, then that means that the local anesthetic will not be cleared as quickly into the bloodstream because you don't have a vasodilation effect. It's just going to be vasoconstriction, so there's not that much blood flowing through there. So it leads to an enhancement in the duration block. Okay, does that make sense? So the action of the local anesthetic kind of lasts longer. It prolongs the duration of action. Okay, so that's local anesthetics. Now, general anesthetics, what you have to know, once again, I highly recommend watching the sketchy video specifically on this one because it's very helpful. But you have the fluorines, which is an inhaled anesthetic, all right? And fluorines lead to increased cerebral blood flow, which can cause increase in intracranial pressure, and also causes a respiratory and coronary deficit or drop. Okay, so those are the two adverse effects: increase in cerebral blood flow, which leads to increasing intracranial pressure, but it also leads to depression, respiratory depression, and coronary vascular depression. All right, and then the one that they really care about for IV anesthetics is propofol. Propofol is a short duration and quick onset because it leads to rapid tissue distribution. So that's why it only lasts for a little bit of time, but it's quick acting. It's going to potentiate GABA receptors and inhibit NMDA receptors. You have etomidate, which potentiates GABA receptors, and what it's really helpful for is that it's hemodynamically neutral. So patients that are like hypotensive or tachycardic, it won't affect them. It won't drop their pressures more. So you could give them etomidate for hemodynamic neutrality. Ketamine's the last one, which inhibits NMDA receptors. Okay. Now, what they want you to know is the MAC. Okay. MAC is just the minimum alveolar concentration. So it's just the minimum amount required to prevent 50% of subjects from moving. Okay. In response to pain. And potency, what they want you to know is that it's 1 over MAC. Okay. So those are questions that they can ask you that are just weird, that don't really relate to the medication, kind of knowing the medication. All right. Next is neuromuscular blocking agents. So you have two types. You have depolarizing and you have non-depolarizing. The depolarizing one is succinylcholine. That's the one that you need to know, okay? What happens is that it produces sustained depolarization, which means that it prevents muscle contraction, right? So if you're constantly depolarized, you can't contract, right? You can't repolarize to make another contraction. So the issue is that the complications of succinylcholine is that you can have increased potassium and calcium. So it can lead to hypercalcemia and hyperkalemia. But it can also increase the risk of prolonged muscle paralysis. So if you see a patient that received anesthesia or like a neuromuscular blocking agent, and they're having a lot of trouble moving their muscles after receiving succinylcholine, okay, it's because this patient has pseudocholinesterase deficiency. Okay, so it's increased risk of prolonged muscle paralysis in patients with pseudocholinesterase deficiency whenever you give someone succinylcholine. So if the patient is given succinylcholine and they say, oh, they have rigidity, muscle rigidity for a longer period of time compared to their other patients, it's because they have pseudocholinesterase deficiency, and it's due to decreased plasma hydrolysis. Okay, I want you to take that away. It's very important. Then the other ones are the non-depolarizing, and they all have curamine. They end in curamine. They have cure in it. And what they want you to know is that patients with myasthenia gravis are extremely contraindicated for taking non-depolarizing neuromuscular agents. Okay, they're very sensitive to the curamines. Okay, so you cannot give patients with myasthenia gravis non-depolarizing neuromuscular blocking agents. Now, a very high yield association with these drugs is malignant hyperthermia. Okay, so what it is that you have excessive myoplasmic calcium accumulation. So you have excessive amounts of calcium accumulating in the myoplasm in your muscle. And it's due to the fact that you have decreased sarcoplasmic calcium release in skeletal muscle. Okay? Increase in sarcoplasmic calcium release in skeletal muscle. So you could treat them by decreasing the sarcoplasmic calcium release in skeletal muscle by giving them dantrolene, which is a ryanodine receptor antagonist. So that decreases sarcoplasmic calcium release. Okay? Very straightforward. Malignant hyperthermia is caused by excessive myoplasmic calcium accumulation. You could give them dantrolene, which decreases sarcoplasmic calcium release. Okay? Now, it's going to be caused by your fluoranes or succinylcholine. Okay, so your potent inhaled anesthetics or succinylcholine. And it's just a hypermetabolic condition. Okay? So just keep that in mind. If a patient comes out of anesthesia and they have a very hypermetabolic condition, like they have hypermetabolic symptoms, then you know that it's probably malignant hyperthermia, and they can ask you the mechanism of action behind it. It's due to excessive calcium accumulation. So you give them dantrolene to block the calcium release. Okay? Very, very important. Next is going to be skeletal muscle relaxants. These aren't too high yield. The only thing I'm going to be talking about specifically is dantrolene. Once again, dantrolene is going to be helpful in treating malignant hyperthermia by preventing the release of calcium from the sarcoplasmic reticulum of skeletal muscles. All right? It's a ryanodine receptor blocker or antagonist. All right. Now, for the opioids, we're going to discuss it later on in psych. And the last thing I will say is capsaicin. It's naturally found in hot peppers, and it's used to decrease substance P, which leads to a decrease in overall pain. I got one question on it. It was stupid, but that's what capsaicin does. Okay. Other than that, the glaucoma therapies we already discussed. We have the beta blockers, the alpha agonists, the diuretics, the prostaglandins, and then our cholinomimetics. But you already know all those glaucoma therapy. All right, that's pretty much it for neurology.